Now, medicine is not only animated by something like a religious vision, but it also requires a thick moral framework for its ongoing direction. And we've heard some of that framework from the traditions within Islam this morning. So to know how to care for patients, we need to know something about what makes what human flourishing entails, how medicine contributes to it. Medical science is less helpful here than one might hope. It does help us to better understand the empirical world, and therefore helps us all refine our efforts to bring about human flourishing. It shows a range of technical possibilities and provides information about what we can reasonably expect as the consequence of choosing one course over another. But even the successes of medical science highlight its limitations. As medical science generates technologies that can be put to ever wider uses, it exposes disagreements about which of those uses are worthwhile. And to pick up on Hassan's rhetorical question, science as it progresses allows us to know both more and less, in the sense, more about what's possible, less, that introduces more confusion about what we ought to do, at least often does. Although medicine proceeds in scientific ways in the care of patients, it does so in pursuit of goals that science can't set, and these goals come from moral traditions and cultures, whether they're religious or otherwise. And in the same way that the influence of a dominant culture on medical practice is often invisible or taken for granted precisely because of its dominance, the influence of religious ideas on medical practice is often invisible in those areas where commitments are shared among different religions and other moral traditions. For example, we generally take it for granted that mending injuries, treating infections, and removing diseased organs are good things to do. That's because the moral commitments that undergird those practices are shared by virtually all moral communities, religious or otherwise. Moral commitments that are shared don't really seem moral at all. They don't seem personal in that sense. The influence of religion on medical practice becomes more visible where the commitments of one tradition diverges from those of another or from the values of the dominant culture, and I'm just going to say we've heard a lot about that this morning, and we can think particularly about the care of patients at the end of life or with very diminished health. I do think, however, that those are tips of an iceberg. Beneath that are disagreements regarding really fundamental questions about what it means to take care of someone, to fulfill our obligation to take care of our neighbor, what it is that we hope for in the face of death, and so on. In the end, for all that's hoped for in scientific and evidence-based practice, clinicians must ultimately act as practical moral philosophers, making judgments about how best to pursue the goals of medicine for a particular patient in a particular context. And I will say here that I think one of the interesting questions for me today in listening to this is to what extent physicians can come to be something like how do they move from strictly just a layperson to a sort of mufti of some clinical capacity, within their own area of expertise, because clinicians have to make these kinds of decisions all the time. And how do they do that without becoming presumptuous about what they know? The third area where religions substantially, I think, impact the practice of medicine, and here I'm just going to sort of state this and maybe leave it for question and answer time if you want to explore it further, is in developing the practices that help physicians become the sort of physicians they know they ought to be. Patients have forever complained with good reason that physicians tend to treat them as objects and rather than as the persons they are. And that, it seems that physicians fall prey to a very human tendency to kind of not take as seriously other people as we take ourselves. We're busy, other people are different, and we don't tend to think about their own internal experiences like we do our own. And that can lead us to treat them as objects rather than as persons. What religions generally do is form their people in practices. I mean, there was a prayer time over the lunch hour. That practice of prayer shapes a person's consciousness, shapes them bodily in their habits to keep them attending to truths that would otherwise be ignored. And I think that influence within medicine, we should at least explore how that might be actually very salutary for the profession of medicine, that its practitioners would have space to continue those practices that form them as members of their religious community, as followers of God, but at the same time also animate their practice of medicine in a way that will benefit patients. And with my 1 minute, let me let me make a couple of comments, again, kind of swinging back to the subject that Professor Brody and Professor Vischer talked about. This private versus public sphere, it seems to me, is clearly contested all the time in the area of medicine. And we take a simple example, which is this issue of conscientious refusals, which Professor Vischer talked about a bit. In conscientious refusals, where a physician or other healthcare worker refuses to provide something that's legal and that patients request, often the assertion is made, or the claim is made, or the argument is made, that what's happening there is the physician or healthcare provider is allowing their personal values to be imposed upon what should be the professional sphere. Very similar to they're allowing their private world to kind of come where it's not welcome, which is into that public sphere. And yet, it seems to me that what's going on there almost always is in fact not so much a bringing of a private into a clearly public, but a dispute about what the commitments are of that professional role. So with respect to reproductive technologies, there's a dispute about whether medicine properly includes the use of this technology or that in this situation and that. And when someone uses the maneuver of, well, you got to keep your private values out, that can feel like a power move, a kind of arbitrary power move that avoids that really sincere disagreement about the content or the substance of those professional commitments. That can lead to frustration, it seems to me, for believers and to a kind of incoherence where they're trying to act like they're keeping these separate when they're really not. And it kind of in a way cuts off the sort of civility, which I agree with Professor Brody is a crucial public virtue that we have to develop to learn to live together peaceably with these sincere disagreements, because that civility requires that we at least be able to give people space for that free exercise of religion and a space to talk about that. So I think here's the challenge. I'll close with this. In medicine, to the extent we maintain this notion of a clearly distinguishable private and public or personal and professional, we tend to create a kind of go along with, it seems to me, a false sense that these can be kept separate. And what that does is it prevents the practitioners from explicitly making sense of how these are actually come together. And if they're not able to make sense of that, then they can't really live into the practice of medicine in a really vocational sense, as a way of living a good and faithful life and serving their neighbor and serving God. And it seems to me that although there are dangers and downsides, risks and benefits, again to use Hassan's metaphor, to having physicians self-consciously practicing from many different traditions in a kind of self-conscious relation to their religious beliefs, that there are risks to shutting that off as well, and that it seems to me that we ought to push that boundary back a bit and at least try to work out peaceable practices of medicine that invite physicians to make sense of this connection between who they are as a religious believer and who they are as a physician, and to care for patients in that really vocational sense, in a public, speaking publicly about what they're doing and helping explain that to others. It seems like it would enrich their own experience, and it would enrich the public sphere and the professional sphere of medicine at the same time. Thank you.
Thank you to all the speakers for your talks. I think we're out of time. In fact, we ran a little bit over. Can we take any questions? 2:20 is great. So okay, so we have questions. Okay. We have 3:20? 10 minutes, okay. Any questions? And after you give your question, please, you can return to your seat so we can keep the flow of the line. Sorry.
Thanks for the wonderful panel discussion. In the context of the ethnography of the Egyptian patient population, do you find, as far as the doctor-patient relationship and going into this public-private sphere, I find that in the United States, as far as a healthcare practitioner, we're very isolated or many of us are so subspecialized that we're isolated from the day-to-day trials and tribulations of a patient. And I was wondering if that, again, extrapolates into the concept of that physicians or caretakers here don't get into the private sphere enough of their patients, and two, is that physicians don't come in at least disclaiming where they're coming from. So I just wanted to, just maybe get an idea of bringing in that cultural context to what the doctor-patient relationship is. And a lot of our ethical issues are, the doctor knows best, especially in third world countries, or they'll do anything that doctor says. Whereas now we have this information age where you're empowering patients and healthcare practitioners. But when do you bring in your personal viewpoint? Because I personally think I'd like to know where that person is coming from that's going to be treating me.
Yeah, that's a really good question. I mean, in the Egyptian context, because it's so religiously homogeneous, and of course 10% of Egyptians are Coptic Christians, and they tend to go to Coptic doctors. I mean, it's not always the case. And Muslim, not always, but there is some kind of religious similarity often between patient and physician. So the physician often feels entitled to argue with the patient and say, why do you think this is haram? It's not haram. And to convince the patient. And that's why I think it's also important to look at some of these sort of like ethical dilemmas of the physicians themselves. And so I look at, for example, with the brain death, there was a case that just really stuck with me, and it was a young anesthesiologist in the ICU, and he came out and he was so devastated because there were a bunch of patients who were all dying around the same time. And at one instance, one of them's heart, stops, and so he starts to resuscitate, and he's a resident, and the attending says to him, "Haram! That person is trying to die. Let him die. Why do you keep resuscitating?" And so he stops, and then the next attending comes to him and says, "Haram! Save him! Why aren't you resuscitating him?" And he was doing this. And I think that because there aren't enough conferences to really work out these issues, sometimes the doctors are confused among themselves. And I mean, I think there's even another level of abstraction once you get to the religious scholars who have no idea what it's like to be in the ICU and just can't even imagine what they're talking about.
Just a brief comment on that. Thankfully, although there are obviously very important disagreements and differences among the different communities, there is, fortunately, it's not all up in the air. So patients don't have, they're not going to go see someone and just have an entirely different practice depending on their tradition. There's a lot that's shared, but it seems to me that because there is on the margins of medicine, and those margins are substantial, because there is no professional agreement about a lot of different practices, it does seem like physicians should cultivate practices and the capacity to, in a candid and respectful way, explain why his or her counsel might be different from someone else, what someone else's would be. So that takes a lot of self-consciousness, takes a little thinking about how one situates oneself within the broader community of professionals, and it takes I think the practice of being respectfully candid about where you're coming from.
Can I just add one thing? I mean, I would just say that also there is a potential danger of mistaking somebody's opinion about a medical procedure and thinking that it's because of religion, when in fact it has to do with access and efficacy. And people aren't always able to articulate which thing it is. And so it's really hard, it's really important to distill just keep asking, what is it exactly that's bothering you about this procedure?
So thank you again for the excellent panel. I'm a Muslim physician who treats a variety of different segments of society as well as different ethnicities and religions. And how does one balance their own religious identity against their American identity of trying to accept all these different cultures and finding a common ground? And in the way I was taught medicine on this campus was you allow the patient to help make the decision, and you're just a surrogate or a guide for that patient. But then when I start adding my own religious values, which I think are very helpful in my commitment to the field, does that compromise my Americanness? And so,
You know, it's interesting. We found in my research, with mine and my research done with colleagues, that physicians from religious communities that are less represented in the United States, which includes Judaism, Islam, and Hinduism, because those are the ones we have enough people respond to surveys to make some inferences about them, are more likely to endorse the notion that they try to keep their religious beliefs and their professional practices separate, and that they accommodate the things that the patients request. So I think people are struggling, it seems like. I mean, this is survey research. It's limited. I don't want to overstate it, but there seems to be some struggle to try to be accommodating in a culture where you're a small minority. I would not want to be trying to prescribe the best way to deal with that. But it does seem to me that that's a real challenge that people face.
I'm not clear where the conflict is, frankly. So I think the Muslim physician should embrace the idea that their Islam will actually make them a better physician. And I don't think they should shy away from it. I think it is very possible to practice as a Muslim physician to try to be true to that tradition. I think that takes a lot of work. I don't by any means claim that I've figured it out, but I certainly think that takes a lot of work. I think it should be sincere. And I think the result of that, dealing with patients of different backgrounds, growing up as a Muslim in this country, you've done that your whole life, if I had to presume. So I'm not sure the practice of your medicine is going to not relate to that, or that you're not going to be capable of doing that. So I actually find that there's very little conflict here. The question I think that you might be thinking or struggling with is, if I have an Islamic value that is in opposition to what my patient's value is, and they ask me for advice on a question, what is my obligation? If that's where you're going, I think that's a little bit trickier. And that's a little bit, but I think if that person in front of you is not Muslim, your obligation is to advocate as best you can what that patient's wishes are. And again, if it gets to the point where it violates your principle, then we consult the legal professor this morning, I guess, to see if we have a case. That was a joke.
Assalamu alaikum. I want to thank you all for yet another really wonderful panel discussion. In light of what Dr. Ehsan was talking about other roles of healthcare providers in terms of patient advocacy and professionalism, I was wondering if any or all of you might address the question of promoting caring and compassion and presence in these days of assembly line, highly technological medicine, where often we are super specialized.
Well, I'll say something question. Maybe provocative to the doctors here, but I actually,
like we haven't already.
Well, I don't know why one person has to be everything. And I mean, I'm just thinking of the days when my own father had terminal brain cancer, and you know, we wanted the most excellent neurosurgeon, and I don't see why we can't why he also has to be every kind of caring I mean, I want him to really focus in on the brain and not be distracted, and then have other people who that's their strength. I mean, like when I think about those hospice nurses as a Muslim, I think paradise must lie under the feet of hospice workers because of what they do, and I saw that. And there are people who have a particular virtue, a particular personality, who are driven towards very caring and very present work. And there are people who are more technical and might excel in that. And given that we have this diversity that we can draw on in community, I think people can take on different tasks, and we shouldn't expect the doctor, the specialist, to do everything.
And here I would say, and I completely agree that may be the possibility in terms of specialty. But I think the onus is on the Muslim physician to be the best possible physician. And the way you do that is to be the best possible Muslim. And so a simple example of what you're describing is on class on Sunday, where Sheikh Amin teaches us. He brought up the point that in the Sunnah we have the idea that when someone addresses you, that you have to turn to face them. Now, I mean, in my practice, all of you probably use electronic medical records. Half the time you're typing, you're not facing the patient. So even that common decency is in our Sunnah. So it's not about whether you're a physician or not. It's just how much have you actually exemplified that Sunnah. I think there should be tremendous confidence for the Muslim that if we actually go back there, it will be very natural for us to be exceedingly good physicians. Now, Again, I'm not saying that's an easy task, but I certainly agree with your point. I do think that's someplace that Muslim physicians need to go. We need to ask ourselves these tough questions. Are we really the best physicians that we can be? And that's not easy, and most of the time, I know personally, the answer is not.
I just would comment briefly that I think this is, again, a place where practices of religious spiritual formation can be helpful, because in a way, in order to do that, to really attend to the patient, which is maybe not necessary for the neurosurgeon, because they can attend to the tumor, but most medical care, if you're going to do it well, requires a balancing of it in hundreds of different values and concerns and applying them to a particular person's situation. And to do that well, you have to really pay attention to them and listen to them. And that requires a kind of resistance to all your natural impulses to get going, to get done, to be, all those sorts of things that is the spiritual disciplines help you develop the capacity to resist.